Hi, I'm Zach Mathey. I'm here with Dr. Ed Kim. Today we're going to talk to you about abdominal trauma.
Great. So on this podcast, we're going to apply the concepts that you learned on the first podcast regarding traumatic injury to the chest and apply it to the pelvis. And those two concepts were that there's a big difference between when it's a blunt trauma and a penetrating trauma, meaning if you get hit by a bat or get hit by a car, you're going to have a different set of injury than if you get shot by a gun or stabbed by a knife. And then the other thing is to think of human anatomy from a standpoint of a structural engineer. Think about the weaknesses, strength, and what's likely to be injured, so that you can almost predict what's going to happen based on what you already know about the anatomy.
Here's just representative photos of two types of injury that we talked about. Blunt injury on the left, that's probably a gentleman who got in a car crash, and that's the imprint of his seatbelt. That's what we call a seatbelt sign. And then on the right, you see a penetrating wound in the right upper abdomen from a gunshot wound. So in generally comparing the abdomen to the chest,
this is the structural engineering part.
We can see that the major differences anatomically is the chest has a big bony thoracic cage that sort of protects the underlying structures and is less pliable and more rigid versus the abdomen, particularly in the front. You have a soft abdominal wall and there's a lot more compliance. And the major structures, though, in the back, like the aorta and the IVC, still have a good amount of protection from the spine and the thick musculature.
Right. On the chest, it seems like a cylinder. I mean, I know the ribs are kind of protection, but they seem a little, they're a little delicate, easily crushed, broken, and you can kind of hurt the stuff in the middle, or at least out in the periphery. But as the scans show, the mediastinal structures are definitely better protected, right? And on the right abdomen, it's a lot busier with all these, guts, intestines, and whatnot up front. They all seem to be at risk there. And then in the back, as you can see in this gentleman, what Zach was pointing out too, there's a lot more protection around the spine and the back muscles, right?
So, thinking about blunt trauma to the abdomen, these obviously you get a lot of. This is a compressive force from a seatbelt in a car crash or a strike with a fist or a bat. So a lot of the structures do have a fair amount of compliance and might bend but might not necessarily break until you get to that excessive force.
Yeah, I think all these intestines, like Zach, with the mesentery and the omentum, they're kind of like floating in this sea of fat. It's like those kung fu movies where you are supposed to absorb the energy, right?
True.
They're able to absorb and disperse, right?
But there are a few structures that don't do that quite as well, and we typically think about our solid organs like your liver and your spleen as being much more likely to crack or break.
And if they crack, not a good situation, are they?
No, as we'll see here. So here we've got two CT scans in patients who had blunt trauma. So on the left, you'll notice that's a cross-section, an axon image showing the liver, and it's cracked in half, as you see. That's a high-grade liver laceration. And on the left side of the photo, around you see fluid, which represents blood from bleeding from the liver.
Right. So free fluid, and then the splenic injury on the right. So free fluid in the setting of a blunt trauma means that it's either a cracked spleen or a cracked liver or both with blood representing, right? And then I guess the other retroperitoneal organs that you could consider are pancreas.
Yeah, you got your pancreas, duodenum.
But not very common.
That would
not in a blunt.
Yeah, that would have to be a pretty high force.
Okay. So free fluid is a very important diagnostic sign, is it not?
It is. It's actually, and with the use of ultrasound or the FAST exam, focus assessment with sonography and trauma, that has really changed the way we manage trauma patients in the trauma bay, because it's very sensitive to detect even small amounts of blood. If you're really good, as low as 100 milliliters of blood, and it's can also be a way to look at the heart.
Right.
And look at the common places where blood accumulates.
Yeah, I mean, this was actually just starting to come into the fore when I was a resident about 10 years ago. And it was very, the whole idea of being able to do this at the bedside in the trauma bay was very convenient and revolutionary, essentially. So let's talk about this scenario.
So, so say we get a patient who's driving on a motorcycle, crashes, goes over the handlebars, and maybe gets hit with the handlebars in the abdomen. That's a very common blunt trauma presentation. Complaining of lots of abdominal pain, maybe has some tachycardia and instability, but is not crashing. So you quickly assess the patient and do a focused sonographic exam or the FAST exam, and you see free fluid. So that you have to think that's blood. That's blood until proven otherwise. So what do we do next?
So if he's stable, then you're going to go to the CT scan.
Yeah,
is that
say
right?
say he stabilizes and looks okay. So you send him to the CT scan because you want to get more diagnostic information before you make your next management choice.
Right.
On the other hand, the patient's becoming more unstable, then that means he's having bleeding and having hemorrhagic shock. So that patient has to go immediately to the operating room to control the bleeding.
From the spleen and the liver, presumably, most likely. Right. And then the CT scan also helps you because some of these injuries can be managed without an operation. Isn't that correct?
Right. So you don't necessarily have to operate on every bleeding liver or spleen. And in fact, if a lot of these injuries can be managed non-operatively with just, and sometimes the bleeding will stop on its own, but if they really are having active bleeding, you can have interventional radiology do an angiogram and selectively embolize the bleeding blood vessel, which is depicted here on the left side of the screen.
Okay. And on the right, that's a non-salvageable, presumably a non-salvageable spleen. The patient was probably hypotensive, kept bleeding, and had to go to the OR. Okay, now let's talk about the other type of trauma to the abdomen, penetrating trauma, like this unfortunate, unhappy gentleman here.
Yeah, so this gentleman, the first thing you see is that when you look at him, a knife sticking out of his abdomen. So, that makes you very worried that he's got some sort of major injury to the structures.
And what kind of structures do you expect to have injury?
Yeah, well, if you think about what's right under there, you've got all your small bowel and your intestines, and those are very much at risk.
So that's a picture of injured small bowel during an exploration.
Yeah, so that definitely shows.
So how do we figure that? How do we assess for small bowel injury or bowel injury in these patients?
Well, the thing is with CT scans, it can be very hard to pick up injury to the intestines, like colon or small bowel. And if you have a penetrating injury to the abdomen, be it with a knife or a gunshot, the rates of
can you do FAST? Is FAST good for figuring out bowel injury?
It's not very good.
So
no.
You're saying CT doesn't have good sensitivity, FAST doesn't have a good sensitivity. Sounds like the only thing you can really count on is opening the patient up and looking.
Yeah, that's actually true. Yeah.
Okay. Well, we'll get back to that in the next couple slides. But so patterns of penetrating trauma.
So obviously, someone gets shot in the abdomen.
They can still get shot in the liver or spleen. Is that right?
Absolutely. They still get stabbed or shot in the liver or spleen. They can still bleed from vessels, like major vessels like the aorta or its branches, veins, or obviously solid organs. And
people with bowel injury, if they don't have associated bleeding, they're usually a little bit more stable. Am I right? And it's more of a problem with delayed sepsis and things like that.
Yeah.
And like we said, it is a bit of a conundrum of diagnosis in that it's hard to diagnose right away. And so I think that brings us to the slide we were referring to, which is this idea of clinical reasoning, the idea of hard sign and soft sign. I think that's a very important concept.
Yeah, this is a super important concept and applies to many fields, but especially in trauma.
Yeah.
So generally, if you get a patient who has some sort of injury, you want to try to evaluate, are there any hard signs that require an immediate intervention?
Hard signs being like obvious problem, obvious, very specific signs that they got a problem. So, like a sword sticking out of their abdomen, they got a problem, which means they need to go to the OR.
Or someone who's hypotensive after a gunshot wound, they need to go to the OR.
Whereas if it's a more ambiguous, questionable signs than a symptom or sign, then you could consider additional studies before you decide to go and do the intervention. All right. So, like for example, For
So a good
penetrating?
example is this. Yeah, I mean, if someone's shot in the abdomen, that's basically a hard sign that there's going to be an injury.
Don't pass go. Go straight
You
to
just
the
go
OR.
straight to the OR.
Got it. Okay. And so for a soft sign,
Maybe a stab wound, if it's not a big knife sticking out of the belly, but, maybe someone stabbed with, a small knife, or we're not really sure.
then you do a wound exploration.
Yeah,
is that
if
right?
they're stable, you might do a
What are
little
you looking for in a wound exploration?
Well, you want to know if the fascia has been violated,
Got
because
it.
that will tell you if the structures underneath are at risk.
What about a flank stab wound? We're talking about how much deeper that is.
Yeah, so, think about the flank, you've got a lot more
Thicker.
fat and muscle and protecting, the retroperitoneal structures.
So that's a soft sign.
So that's usually a soft sign.
So
yeah.
to evaluate that would be a CT.
You get a CT scan, for
Right.
example.
That's a stab wound, though, not a gunshot wound to the flank. Gunshot wound to the flank is the same thing.
Yeah.
It's a hard sign. Great. So I think, and then fast is also another way. Is that right?
Yeah, you could do a fast.
So easy. So you do it regardless of whether you get a scan or not. Huh? And so let's that allows. I think that kind of helps us organize our thoughts about penetrating trauma.
Mhm.
You'd agree, like
Yeah.
on the left.
Yes, I think, like we talked about the chest, gunshot wounds are much higher energy. So threshold to take the patient to the operating room is basically every patient with a gunshot wound is going to the operating room for at least an operation to evaluate for injury.
Mm-hmm.
And then stab wounds, it depends on the situation. Your threshold is still pretty low to take them to the operating room.
And then the location of
And
the
then
stab.
the location for stab wounds, location also matters, in terms of your suspicion that something's been injured.
And so I think retroperitoneal injury is something that we should probably wrap up with, because we're talking about that gunshot wound to the back. Again, there's going to be a problem, but stab wound to the back.
Yeah, this is on the left a nice picture showing all the different retroperitoneal structures. So it's a good anatomical review. And these are the things you're going to think about when somebody gets stabbed to the back. Do they have a kidney injury? Is their colon been hit? Could even their aorta or IVC have been injured? So these are the structures you want to consider and evaluate.
Okay, great. So in summary, I guess we can say when you have a blunt trauma to the abdomen, you think about the liver and spleen pretty much. Bowel a little bit, but it's not really
Not as common.
Except in that first picture we showed, like the seatbelt sign, right?
Yeah.
Because you can imagine that's like a strap
It's a big
push
compressive force.
against the spine, so
Yeah.
you could probably really mess up your intestines that
Yeah.
way. And for penetrating trauma,
So, you want to think about the mechanism. Is it a stab wound with a big knife or a little knife? Is it a gunshot wound? And where, for a stab wound specifically, what location they've been stabbed in will kind of decrease or increase your suspicion of what structures have been.
and the pattern being different is that bowel injury is much more common.
Yeah.
But all the bets are off a little bit with GSW in terms of
Totally.
other vascular injury. And then lastly, I think you really enjoyed this concept.
I think the idea of hard versus soft signs in trauma is an important one. Hard signs being anything that will make you go straight to an intervention, whether it's the operating room
It's
or
specific, it's
angiography.
accurate, the rates are high
Yeah.
in terms of what you can expect in terms
Yeah.
of injury. Is that correct?
That's great.
Great. Thank you again for listening. And we'll see you again
Next time.
next time.